Hi everyone, this is Dr. Ankit Goel, your mental health nursing faculty at NNL 1. I welcome you all in this video. In this video, we are going to discuss some of the important mental health nursing questions from NORCET 8.0 exam. So prelims और mains के important mental health nursing के questions को हम discuss करेंगे, so that you get an idea how the questions are framed. साथ ही साथ you get to know कि what are the important topics or areas from which the questions are being asked. So जब हम क्वेश्चन डिस्कस करेंगे हम कुछ इंपॉर्टेंट पॉइंट्स को भी डिस्कस करेंगे हर टॉपिक में से. सो लेट्स कम टू द फर्स्ट क्वेश्चन. पहला क्वेश्चन है दैट अ 25-year-old मेल डायग्नोज्ड विद स्किज़ोफ्रेनिया प्रेजेंट्स विद पर्सिक्यूटरी डिल्यूजन्स. So despite showing significant improvement on risperidone, the person stops taking the drug and developed symptoms again. So what is the next step in management? So let's see how to approach such question. So always I say try to identify some keywords in this question. Patient का diagnosis they have mentioned is schizophrenia. Now schizophrenia हमें पता है it's a psychotic illness, and what is the preferred treatment? We give antipsychotic. So we know risperidone क्या है? Risperidone is a second generation antipsychotic. Patient ने improvement show किया, but now patient has stopped taking the drug or again symptoms have come back. So next step in management, let's see the options. Start risperidone syrup. Again, patient is not taking medication orally, so may not also take this syrup. Option B, discontinue risperidone and observe the patient without medication. Will you do this? No. We know in the management of schizophrenia, patient को यहाँ पे symptoms हैं, so we have to give antipsychotics. So again, that is not the correct option. Injectable or depot risperidone, or start CBT only. So again, we will not give only CBT, we have to give antipsychotic. So the answer here is injectable if it depot risperidone. So let's talk about this very important topic, that is long acting injectable, that is LAI antipsychotics, जिन्हें हम depot antipsychotics भी कहते हैं. So sometimes we can give the patient antipsychotics through intramuscular injection. Now this can be used especially जो patients they are having poor compliance to medication, patient is not taking the drug orally. So especially in those cases we can use these depot antipsychotic. तो जब हमने patient को intramuscular injection दिया, so for the next 2 weeks, sometimes next 1 month or even longer तक हमें कोई और medication देने की जरूरत नहीं है, because the medicine will be slowly released in the body from that site. So especially useful in those patients those are not compliant to their oral medication. Sometimes patient may even prefer this mode of treatment, that give us depot antipsychotic, then also we can give these injection. Now when we are giving these antipsychotics, remember the important technique. So what is this technique known as when we give these depot antipsychotic? Yes, this is known as Z-track technique. Very important to remember, it's a PYQ. तो जब हम ये डेपो एंटीसाइकोटिक्स देते हैं, सी वी आर गिविंग द इंजेक्शन इंट्रामस्कुलरली परपेंडिकुलरली, वी आल्सो पुल द स्किन लाइक दिस. सो व्हेन वी आर टेकिंग आउट द नीडल वी रिमूव दिस हैंड, सो देयर इज अ जेड ट्रैक व्हिच इज फॉर्म्ड, सो दैट जब हम नीडल को निकाल रहे हैं इट इज प्रिवेंटिंग द लीकेज ऑफ द ड्रग फ्रॉम द मसल टू अदर टिश्यूज. So this is the Z-track technique which is used when we are giving these depot antipsychotics. Let's also discuss some drugs which are available in these depot antipsychotics. So we'll discuss some first generation antipsychotic and some second generation antipsychotic जो depot antipsychotics में available हैं. जब हम first generation antipsychotics देखते हैं depot antipsychotics, they are having oil base. So यहाँ पे हमें test dose देने की जरूरत होती है, while जो second generation है they have a aqueous base. So यहाँ पे हमें test dose देने की जरूरत नहीं होती. So let's remember some of these drugs. First generation antipsychotics को हम याद रख सकते हैं with this mnemonic Fizzy PH. यहाँ पे F से there are two drugs you can remember. One is flupentixol, one is flufenazine. Z से remember zuclopentixol, P से pipotazine and H से remember haloperidol. Second generation antipsychotic में you can remember it with the mnemonic Paro. So what are these drugs? Remember P से paliperidone, A से aripiprazole, R से risperidone जो क्वेश्चन में ऑप्शन है, and O से olanzapine. So these are some of the drugs which are available as depot antipsychotic. So the right answer of this question is injectable or depot risperidone. Let's discuss the next question. So again you will see another question is on antipsychotic. So antipsychotic is a very important topic. Sometimes questions are asked. A client is prescribed clozapine therapy. Now what is clozapine? Please remember clozapine is a second generation antipsychotic. एंड ऑल्सो वी नो जब हम क्लोजापिन देखते हैं डिस्कस करते हैं, वी ऑलवेज रिमेंबर कि व्हेन डू वी यूज क्लोजापिन. क्लोजापिन इज यूज्ड इन ट्रीटमेंट रेजिस्टेंट स्किज़ोफ्रेनिया. सो क्लोजापिन इज यूज्ड इन ट्रीटमेंट रेजिस्टेंट स्किज़ोफ्रेनिया. इसका मतलब है इफ द पेशेंट इज नॉट शोइंग रिस्पॉन्स टू एटलीस्ट 2 एंटीसाइकोटिक्स, so then we can use clozapine. तो यहाँ पे patient is prescribed clozapine. The nurse instructs the client to return for weekly monitoring of which of the laboratory values due to a potentially life-threatening adverse reaction. So the options are A. Liver enzymes, B. Serum electrolytes, C. White blood cell count, or is it D. Blood glucose level. So which is the important lab value which you have to regularly monitor? So what is the right answer? Yes, the answer is that is the white blood counts. So let's discuss some serious side effects of clozapine. और हमने एक mnemonic discuss किया तो to discuss some of the serious side effects with clozapine, that was SAM. So some of the serious side effects with clozapine include SA. क्या है? SA है seizures. Seizures can occur with clozapine, and usually what we do, then we can start in the treatment, we can start anti-epileptic drugs अगर पेशेंट डेवलप कर जाता है सीजर ऑन क्लोजापिन. ए अगेन इज वेरी इंपॉर्टेंट, ए ग्रैन्युलोसाइटोसिस, दैट इज डिक्रीज इन द डब्ल्यूबीसी काउंट, स्पेशली द एब्सोल्यूट न्यूट्रोफिल काउंट. तो अगर पेशेंट इज ऑन क्लोजापिन एंड देयर इज डिक्रीज इन दीज काउंट, देन व्हाट वी हैव टू डू, वी हैव टू स्टॉप द ड्रग. So if the WBC count is less than 3000 per millimeter cube, या ANC is less than 1500 per millimeter cube, we have to stop the drug. So let us see a clinical situation. So we are starting a patient on clozapine. Patient comes to us with fever, with sore throat, and with tachycardia. So what are we suspecting? We may be suspecting infection हो सकता है, and one of the reason could be because of A granulocytosis. So always check these counts, and if these are low, then you have to stop the drug. In fact, जब हम clozapine शुरू करते हैं, we regularly monitor these counts. In fact, for the first 6 months, जब patient हमारे पास आता है, we do this every week. So every week for the first 6 months, we have to monitor the counts, and for the next 6 months, so first 6 months we have to do it every week, next 6 months we have to do it every 2 weeks, and then also we will not stop. After that we will do it every month. So very important to remember which is the important serious side effect of clozapine which requires close blood monitoring. It is agranulocytosis. So यहाँ पे the answer is, we'll check the WBC. Also remember, M say myocarditis can also occur with clozapine. Again, if it develops, we may have to stop the drug. So the right answer of this question is we have to regularly monitor the white blood cell counts. Let's see the next question. Again, you will see so many questions have been asked on antipsychotic. Next question is, which category of side effect is most commonly associated with the first generation, that is typical antipsychotic medication? Option A is metabolic side effect, that is weight gain, hyperglycemia. Option B is extrapyramidal symptom, EPS, example dystonia, Parkinsonism, akathisia, tardive dyskinesia. C है anticholinergic side effects like dry mouth, constipation, or is it D, cardiovascular side effect like orthostatic hypotension? So what is the right answer? So let's see. We know that first generation and second generation antipsychotic, we have two set of antipsychotic. First generation को हम typical antipsychotics भी कहते हैं, second generation को हम atypical antipsychotics भी कहते हैं. Mechanism of action of first generation is they are D2 antagonist, or second generation they are not just D2 but also 5-HT2A antagonist. How to remember? दोनों 2 हैं, D2 5-HT2, and remember A से हम याद रख सकते हैं atypical. So this is how you can remember the important mechanism of action. Now when we talk about EPS, EPS क्या होता है? Extrapyramidal symptoms. ये कुछ motor side effects हैं which can occur with these antipsychotic. EPS occurs because of D2 antagonism. So remember, usually we say that EPS is more with the first generation antipsychotic and it is usually less with the second generation antipsychotic. Whereas when we talk about the metabolic side effect or metabolic syndrome, जैसे कि weight gain, hypertension, डायबिटीज मेलाइटस, कार्डियोवैस्कुलर डिजीज, डिसलिपिडीमिया, ये जो मेटाबॉलिक सिंड्रोम है, रिमेंबर इट इज यूजुअली लेस विद फर्स्ट जनरेशन एंड यूजुअली वी से इट इज मोर विद द सेकेंड जनरेशन एंटीसाइकोटिक. बट अगेन रिमेंबर वन इंपॉर्टेंट एक्सेप्शन जब हम बात करते हैं वेट गेन की, क्लोरप्रोमाजीन. क्लोरप्रोमाजीन इज वन ऑफ द फर्स्ट जनरेशन एंटीसाइकोटिक जिसका जो वेट गेन रिस्क है इज मॉडरेट. While remember drugs aripiprazole and ziprasidone, so you can remember it with the mnemonic A to Z. So remember aripiprazole and ziprasidone, these are second generation antipsychotic, but they have low risk of weight gain. So sometimes such exceptions can also be asked in the question. तो अगर हम compare करें chlorpromazine को with aripiprazole ziprasidone, तो प्लीज रिमेंबर क्लोरप्रोमाजीन है तो फर्स्ट जनरेशन बट इसका मॉडरेट रिस्क है वेट गेन, वाइल एरिपिप्राजोल जिप्रासिडोन ये है सेकंड जनरेशन बट इनका लो रिस्क है वेट गेन. प्लीज रिमेंबर दिस. सो एज वी हैव डिस्कस्ड यूजुअली ईपीएस इज मोर विद first generation. This is one of the side effects which can be commonly seen with the first generation antipsychotic. So as we have discussed, usually metabolic side effects is more with the second generation. Also anticholinergic side effects can occur with some of the drugs like chlorpromazine because they have anticholinergic property. Also cardiovascular side effects may also occur with some of the drugs, but if it is asked which is most commonly seen, then we'll go with EPS, that is extrapyramidal symptoms. In fact, we have talked about some of these important EPS which can occur with a mnemonic DP at night. So D से क्या है? dystonia. So what is dystonia? Now we know in dystonia there is sudden contraction of a group of muscle. So remember acute dystonia, it is one of the earliest EPS which can occur. So sudden contraction of muscle होगा, patient may come to us with torticollis, that my neck is twisted to one side, or there is oculogyric crisis, my eyes are turned upwards. Remember management में we will give anticholinergic drugs like promethazine, benztropine. Then P से remember it is Parkinsonism, drug induced Parkinsonism या pseudo Parkinsonism. Patient may come to us with tremors है, rigidity है या bradykinesia है. Again treatment is anticholinergic drugs like trihexyphenidat. यहाँ पे हम oral भी दे सकते हैं. Usually acute dystonia में will give drugs parenterally. Then remember A से है akathisia. सबसे common EPS कौन सा? It is akathisia. akathisia का मतलब restlessness. पेशेंट सब्जेक्टिवली हमें रिपोर्ट करेगा कि मैं रेस्टलेस फील कर रहा हूं अंदर से, और जब हम बाहर से पेशेंट को ऑब्जेक्टिवली देखते हैं पेशेंट विल नॉट बी एबल टू स्टे स्टिल, पेशेंट में बी मूविंग, तो पेशेंट बड़ा रेस्टलेस है. रिमेंबर यहाँ पे द प्रेफर्ड ड्रग इज बीटा ब्लॉकर लाइक प्रोप्रानोलोल. देन टी से है टार्डिव डिस्काइनेसिया. टार्डिव का मतलब है लॉन्ग टर्म यूज. तो क्वेश्चन में दे में टेल यू कि पेशेंट इज ऑन एंटीसाइकोटिक फॉर मेनी मंथ्स और मे बी ईयर्स एंड पेशेंट में डेवलप सम एबनॉर्मल मूवमेंट्स जैसे कि लिप स्मैकिंग या फिर चूइंग मूवमेंट्स है या टंग प्रोट्रूजन मूवमेंट है या हैंड में यूल सी कोरिफॉर्म पियानो प्लेइंग लाइक मूवमेंट्स. यहाँ पे वी विल गिव वीमैट 2 इनहिबिटर्स लाइक वेल्बेनाजीन, टेट्राबेनाजीन. एंड एन अगेन वेरी इंपॉर्टेंट, एन से है न्यूरोलेप्टिक मैलिग्नेंट सिंड्रोम. अगेन इट इज लाइफ थ्रेटनिंग. पेशेंट ऑन एंटीसाइकोटिक में कम टू अस विद हाई ग्रेड टेम्परेचर, इंक्रीज इन द सीपीके, क्रेटिनिन फॉस्फोकाइनेज लेवल्स बढ़ा हुआ है, मसल रिजिडिटी है, अदर सिम्टम्स में भी देयर स्वेटिंग, टेकिकार्डिया. In fact, TLC count may be raised, patient may be confused, even the liver enzymes may also be raised. Remember, यहाँ पे first step will be we will stop antipsychotic and drug of choice अगर पूछें then it will be dantrolene. Other dopamine agonist can also be used like amantadine, bromocriptine, but drug of choice if they ask you it is a skeletal muscle relaxant, dantrolene. So briefly, I've also covered these important EPS because sometimes you'll see clinical picture may be asked related to these EPS. Now let's discuss the next question. Now again many questions have also been asked from depression. So again a very important topic जब आप revise कर रहे हो depression, again how to diagnose, specifiers, management, all these are important. So let's see this question. The question is, which type of depression is often characterized by severe anhedonia, loss of pleasure, early morning awakening, psychomotor retardation or agitation, significant weight loss, excessive guilt, often with a distinct quality different from the normal sadness. So can you appreciate here they are giving you more severe symptoms or more severe form of depression. In fact this question is on the specifier. Now we have talked about specifier. तो हम जब diagnosis बनाते हैं depression का और MDD that is major depressive disorder का, sometimes patient may be having some unique features, तो हम diagnosis के साथ we add some specifiers. So let us see the option. Option A है atypical depression. Option B है melancholic depression. Option C है dysthymia, that is persistent depressive disorder. No, dysthymia we know is a milder form of depression जिसमें symptoms are present for at least 2 years. So this is not the case of dysthymia. Seasonal affective disorder we know that sometimes depression may occur in certain seasons. For example, let us say patient says that जब भी winters आती है, whenever there is winter I develop depression. So again depression is occurring in winter and when the season goes my depression improves. So whenever there is winter the symptoms would come and जैसे जैसे season change होता है my symptom would improve. So can I say कि यहाँ पे depression is again and again occurring in a particular season, so that is known as seasonal affective disorder. So in this scenario we have ruled out it is not dysthymia, it is not seasonal affective disorder. So let's discuss what is melancholic depression, या फिर we can add the specify depression with melancholic features, also known as involutional melancholia या melancholic depression. It usually represents a more severe form of depression, usually may occur in old age but of course can occur even in a relatively younger age. So it is representing more severe form of depression. So melancholic features या melancholic depression में what happens, see this, there is loss of pleasure nearly to all the activities. Patient says, you know, even the small activities, I am not getting any pleasure. Also, there is lack of reactivity to all the pleasurable stimuli. Even, you know, जो थोड़े बहुत भी pleasurable stimuli से patient को, you know, would enjoy, वो सब reactivity खत्म हो गई. So again, this is suggesting a more severe form of depression. So out of these, at least one should be present, and from the remaining, then at least 3 or more should be present. So let us see some of the other symptoms. यहाँ पे एक distinct quality of depressed mood होगा. Patient may report that I am feeling empty, my mood is empty, या बहुत profound despondency feel कर रहा हूँ, या despair feel कर रहा हूँ. Patient may report of early morning awakening. Early morning awakening का मतलब है patient says I wake up 2 hours before my usual waking time. Patient may report that my symptoms or my mood is worst in the morning. By the time evening come थोड़ा improve होता है. So remember, early morning awakening हो रहा है, mood is worse in the morning. Very important, excessive guilt. Sometimes this is given in the question. Patient is having too much of excessive guilt. So this may be seen. Patient may have anorexia, yeah, weight loss is there, and also psychomotor disturbance. Again, it can increase, it can decrease. So psychomotor disturbance decrease हो सकते हैं, या sometimes it can increase. So out of these, at least 3 or more should be present, और पहले दोनों में से at least 1 is present, then we say patient को melancholic depression. And now can you appreciate in this question, patient is having severe anhedonia, early morning awakening, psychomotor retardation or agitation, significant weight loss है, excessive guilt है, and a distinct quality of mood different from the normal sadness. So again, all these things are telling me कि यहाँ पे patient को है melancholic depression. Now how to remember features of atypical depression? So let's discuss atypical depression also. देखो नाम में ही लिखा हुआ है ना atypical. So यहाँ पे जो depression में हमें symptom मिलते हैं उससे थोड़ा सा अलग मिलेंगे. So let me discuss, you know, features of atypical depression and let me give you a mnemonic. तो अगर मैं आपसे पूछूं usually depression में how is the will of the person, you will say the will is low. So remember the mnemonic. यहाँ पे हम कह रहे हैं कि atypical depression है या atypical features हैं. So यहाँ पे mnemonic है my will high. तो M से क्या है, मूड रिएक्टिविटी. देखो यूजुअली डिप्रेशन में क्या होता है, दैट मूड डजंट ब्राइटन अप इवन इन अ पॉजिटिव इवेंट, बट यहाँ पे एटिपिकल डिप्रेशन है, तो मूड ब्राइटन्स इन रिस्पॉन्स टू अ पॉजिटिव इवेंट. सो पेशेंट सेज जब भी कोई पॉजिटिव इवेंट आता है आई फील दैट माई मूड ब्राइटन्स. तो मैं अगर किसी पार्टी में जाता हूँ तो आई मे फील अ बिट यू नो हैप्पी, थोड़ा मूड मेरा ब्राइटन हो जाता है. नो W से वेट. Now usually we discuss कि डिप्रेशन में because of decrease in appetite weight low हो जाता है. So here it is atypical. So remember weight gain, appetite increased. I से remember interpersonal rejection sensitivity. Interpersonal मतलब आपसी संबंध में rejection sensitivity. So patient is sensitive to rejection. So there may be certain events, you know, जो neutral हो या बहुत mildly hurt कर रहे हो, तो patient feels rejected by others very easily. So interpersonal rejection sensitivity can occur in atypical depression. Else again, interesting feature, laden paralysis. So laden paralysis का मतलब patient को लगता है as if जो मेरी extremities है, मेरे hands है, मेरे legs हैं, as if they're laden with something heavy. कोई heavy weight उन पे रखा हुआ है जिससे मुझे लगता है कि मैं उनको move नहीं कर पा रहा. So I feel paralyzed. So limbs feel heavy. So this is laden paralysis. And again you can remember H से यूजुअली हमें पता है डिप्रेशन में स्लीप में डिक्रीज इंसोम्निया और सम केसेस में हाइपरसोम्निया भी हो सकता है. ये एटिपिकल डिप्रेशन है, तो यहाँ पे पेशेंट रिपोर्ट्स ऑफ हाइपरसोम्निया, दैट इज आई एम स्लीपिंग एक्सेसिवली इवन इन द डे टाइम आई एम स्लीपिंग. सो ये फीचर्स हैं एटिपिकल डिप्रेशन के. अगेन रिमेंबर व्हेन वी आर गिविंग ड्रग्स इन एटिपिकल डिप्रेशन, ड्रग्स लाइक SSRIs, bupropion, MAO inhibitors, they may show good response in these patients. But remember one point कि TCAs, tricyclic antidepressant, usually have poor response, so no response, or usually show poor response to atypical depression. So sometimes these specifiers may also have some changes in our treatment or management. Also remember in melancholic feature, we are discussing the melancholic features mein there is more severe form of depression. Also remember there is increased risk of suicide. In depression, there is increases even, higher, remember, in melancholic feature. So the right answer of this question is that the patient has melancholic depression. Now let's discuss the next question. Again, a question on depression. Which of the following is the therapy of choice for depression? Options are cognitive behavior therapy, CBT, systematic desensitization, flooding, psychoanalytical psychotherapy. Again, I think we can answer this question. So we have discussed, जब हम बात करते हैं treatment of depression, we know in the drug of choice it is SSRI, and we've discussed in the therapy of choice, what is the answer? It is CBT, cognitive behavior therapy. CBT includes two techniques. One is the cognitive technique, so we are changing the cognition, thinking, and also we are changing the behavior. Systematic desensitization is a form of behavior therapy. Systematic matlab stepwise we are desensitizing the anxiety. Usually we use it for some of the anxiety disorders like agoraphobia, specific phobia. So for those conditions we may prefer systematic desensitization. Flooding is also behavior therapy which can be used for those conditions. Psychoanalytical psychotherapy means that we are trying to see that the symptoms may be related with certain unconscious conflicts with certain childhood memories. We're trying to bring those things into awareness. So psychoanalytical psychotherapy. But remember, the therapy of choice for depression is CBT. Let's discuss the next question. Which of the following scale is used to assess depression in community setting? So some students said it was mentioned community setting or primary health center. So see the option. The options are HAM-D, Beck Depression Inventory, Montgomery-Åsberg Depression Rating Scale, or MADRS, and one is PANSS. Now, in fact, you can see A, B, and C, all these are scales used in depression. So, a very interesting question. Let's first rule out what is option D. So, option D is PANSS, that is positive and negative syndrome scale. Now this, I always say sometimes when you're not able to, you're not able to remember, try to just see the name. कभी-कभी आप देखोगे सिर्फ नाम देखोगे तो you'll be able to come to the answer. So positive and negative syndrome scale, if I ask you, it is used for which condition? So you'll say positive symptom, negative symptom, they are seen in schizophrenia. Very good. So they are seen in schizophrenia. So this we can rule out. Now let's talk about some of these scales. Now when we talk about HAM-D, what is HAM-D? It is Hamilton Rating Scale for D for depression, and BDI, it is Beck Depression Inventory. Now if you just see the name, now please remember HAM-D is a clinician rated scale. That means again a clinician is required when we are using the scale. So there is some form of training is required for the scale. Also in fact the MADRS, that is MADRS, that is also a clinician rated scale. Now when we talk about BDI, that is Beck Depression Inventory, remember it's a patient rated scale. So patient themselves can use the scale. There are other scales such as the geriatric depression scale, that is GDS. Also remember that is PHQ, that is patient health questionnaire. These are also patient rated scale for depression. So in a community, where we may not have trained personnel, we may use the patient rated scales for the assessment. Now sometimes, when you're seeing such questions, always try to see, we're talking about inventory. So we are giving a set of symptoms the person can assess. So again, if you see the name itself, remember the answer here is Beck Depression Inventory can be used in the community setting. Now let's see the next question. Now in a way, again, this is a question from the etiology of depression. A person made a small mistake at work and he started feeling that he will be immediately fired. So can you appreciate something small negative thing हुई है और उससे he is just assuming the worst possible outcome despite having no indication from his employer. So there is no such indication from the employer, but in his thinking, can you appreciate कि एक छोटा सा negative event हुआ and उसने he is thinking कि इसका worst possible अब outcome होगा. So which cognitive distortion is this? Options are catastrophizing, personalization, filtering, emotional reasoning. Now let's talk about the cognitive theory. Cognitive theory दिया था Aaron Beck ने for depression. Now Aaron Beck said that normally all of us have automatic thoughts. So normally when you're sitting, when you're observing your thought, आप देखोगे automatically हमारे mind में thoughts flow कर रहे हैं. जिन लोगों को डिप्रेशन है, एरनबेक सेड दैट दे डेवलप नेगेटिव ऑटोमेटिक थॉट्स. तो पेशेंट समटाइम्स विद डिप्रेशन कम एंड से सर विदाउट एनी रीजन मेरे माइंड में ना नेगेटिव ऑटोमेटिक थॉट्स आ रहे हैं, जिनको एरनबेक ने कहा ये हैं कॉग्निटिव डिस्टॉर्शंस या कॉग्निटिव एरर्स. ये नेगेटिव इनएक्यूरेट वेज हैं ऑफ थिंकिंग या ऑटोमेटिक नेगेटिव थॉट्स. इनफैक्ट जब हम सीबीटी यूज करते हैं, उसमें जो कॉग्निटिव थेरेपी है उसमें हम इन नेगेटिव ऑटोमेटिक थॉट्स को आइडेंटिफाई करते हैं, वी ट्राई टू करेक्ट देम. Now, one of the cognitive distortions is catastrophic thinking. Catastrophe मतलब कुछ बहुत negative आ गया है, बहुत ज्यादा big, something big negative has come. So this is catastrophic thinking. यहाँ पे thinking that the worst will happen without considering any positive outcome. तो as you can see in this question, ऐसा ही हो रहा है ना. So there is catastrophizing or catastrophic thinking which is seen in this scenario. Let's discuss some of these cognitive distortions so that you have an idea कि what is cognitive distortion. So you can remember it with a mnemonic PCM soda. So let me discuss some of these cognitive errors or cognitive distortion. One is personalization. देखो as the name suggests, personalization मतलब self reference to external events. So patient tries to personalize all the external events जिसका कोई basis नहीं है या कोई connection का कोई basis नहीं है. For example, a friend did not do well in the exam. पर्सन स्टार्टेड थिंकिंग कि उसने अच्छा एग्जाम या उसके नंबर इसलिए अच्छे नहीं आए क्योंकि मैंने उसको एक दिन पहले अपने नोट्स नहीं दिए. नाउ व्हाट इज हैपनिंग, वो सेल्फ रेफरेंस कर रहा है टू द एक्सटर्नल इवेंट. बट ऐसा कोई नहीं कि फ्रेंड हैज फेल्ड बिकॉज ऑफ दैट, ही हैज फेल्ड बिकॉज ही डिडंट स्टडी. सो दिस इज पर्सनलाइजेशन. सो पी से रिमेंबर पर्सनलाइजेशन, सी से कैटास्ट्रोफिक थिंकिंग जो भी हमने डिस्कस किया, एम से रिमेंबर मैग्निफिकेशन एंड मिनिमाइजेशन. सो मैग्निफिकेशन करना या फिर मिनिमाइज करना. सो एरर इन इवैल्यूएशन ऑफ एन इवेंट. सो मैग्नीफाइंग या मैग्निफिकेशन का मतलब है ओवर वैल्यू करना, एग्जैजरेट करना नेगेटिव सिग्निफिकेंस ऑफ एन इवेंट, और मिनिमाइजेशन का मतलब है अंडर वैल्यू या मिनिमाइज करना इंपॉर्टेंस ऑफ एन इवेंट. सो दिस इज मैग्निफिकेशन एंड मिनिमाइजेशन. नेक्स्ट इज एस से है स्पेसिफिक एब्स्ट्रैक्शन. सो स्पेसिफिक एब्स्ट्रैक्शन जैसे हम देख पा रहे हैं नाम से, फोकस ऑन अ सिंगल डिटेल. सिंगल डिटेल पे फोकस करना और इग्नोर करना बाकी इंपॉर्टेंट एस्पेक्ट्स ऑफ एन एक्सपीरियंस. फॉर एग्जाम्पल, a person gave a speech, everybody applauded, सबने clap किया, but there was one negative feedback. Now the person is only focusing on that one negative feedback and says कि my speech was not good. तो ये है specific abstraction. Over generalization का मतलब है over generalize करना, forming conclusion on the basis of single event. So person may say that one thing that didn't go well in the morning, तो patient may say, person may say कि now the entire day will go bad. So this is over generalization. The next is, remember D से dichotomous thinking या absolutist thinking, all or none या nothing thinking, या तो सब कुछ black देखना या white देखना. So person may say you are the best person I know, and on another occasion person may say you are the worst person I know. So ये है dichotomous thinking, या तो सब अच्छा देखना या सब खराब देखना. And A से है arbitrary inference. Now arbitrary inference में drawing conclusion without sufficient evidence. So बिना एविडेंस के कंक्लूजन्स ड्रॉ करना. फॉर एग्जाम्पल, पर्सन में से दैट सबको लगता है कि आई एम अ लूजर. नाउ हाउ डू यू नो दैट एवरीबडी इज थिंकिंग अबाउट दिस, और व्हाई वुड एवरीबडी जस्ट थिंक अबाउट यू. तो ये है आर्बिट्री इन्फरेंस की कंक्लूजन ड्रॉ करना विदाउट एनी सफिशिएंट एविडेंस. सो ये कुछ कॉग्निटिव डिस्टॉर्शंस हैं व्हिच कैन अकर इन डिप्रेशन. Now let's see the next question. Again, you'll see many questions being asked on drug. Which of the following drug does not have anti-suicidal property? Again, in different drugs we have been discussing this point. So let's see this. They have combined this into one question. Now ketamine is an anesthetic agent. It's a NMD antagonist, but we know it has also certain roles in psychiatry. Again, it has antidepressant effect. So ketamine, remember, it also has anti-suicidal property. And one more point, remember, usually we talk about the onset of action of antidepressant. We usually say it takes time, but ketamine is one of the drugs which has a rapid onset of action. Now clozapine is a second generation antipsychotic, and we have discussed ki kaun si antipsychotic has anti-suicidal property. It is, remember, clozapine. Mood stabilizer with anti-suicidal property, again we have discussed, it is lithium. So all A, B, C, they have anti-suicidal property. Lamotrigine again is a mood stabilizer but does not have anti-suicidal property. Also remember one important technique, or one important treatment modality which also has anti-suicidal property. Remember even ECT. So we've talked about this in the management. The patient with depression having suicidal thoughts, in that scenario ECT may be preferred. So again, ECT also has a, in a way you can say, anti-suicidal property. Now let's come to the next question. Now again the question is on the drug of choice for OCD. So even in the previous NORCET there were questions on OCD. So again a very important topic. So the option is fluoxetine. Now fluoxetine is what? It's a SSRI. Clonazepam, we know it's a benzodiazepine. So always when you see the question, see the option, try to see in which category the drug is. Clomipramine, we know it's a TCA, and risperidone, we know it's a second generation antipsychotic. So tell me, what is the drug of choice for OCD? Yes, the drug of choice for OCD is SSRI. So here the answer is fluoxetine. So let us talk about the treatment. Now in the OCD management, we have drugs, we also have therapy. So drugs, may we have two first line drugs. So we have two first line drugs. One is SSRI, like fluoxetine is there, sertraline, even fluvoxamine is there, and other SSRIs are there. And also we have one TCA which is approved as a first line agent for OCD, that is clomipramine. So please remember, if both these drugs are asked, please remember drug of choice is SSRI because we know it has less side effects, better tolerable drug. Now in psychotherapy, again we have one of the modality CBT, and especially exposure and response prevention, that is ERP. Now what is ERP? Now suppose एक patient को obsession of contamination है, मतलब patient को बार बार repetitive thoughts आ रहे हैं of contamination, like my hands are dirty, the things around me are dirty, and person is having compulsion of hand washing. So इसमें हम क्या करते हैं? We expose the patient to the एंजाइटी प्रोवोकिंग स्टिमुलाई. फॉर एग्जाम्पल हमने पेशेंट के सामने डर्ट रख दिया, तो अब उसको रेपिटेटिव थॉट्स आ रहे हैं एंड नाउ ही वुड वांट टू वॉश हिज हैंड. तो इसमें हम क्या करेंगे? वी विल प्रिवेंट द रिस्पॉन्स ऑफ हैंड वॉशिंग. तो ये है ERP. सो रिमेंबर वी हैव टॉक्ड अबाउट ड्रग ऑफ चॉइस SSRI. साइकोथेरेपी में थेरेपी लाइक ERP कैन बी यूज्ड. Now if I ask you treatment of choice for OCD, then the answer will be a combination of drugs and therapy. So the answer here is option A, that is fluoxetine, which is a SSRI. Again, let's see the next question. So another question is asked on the management. So previously उन्होंने दो question पूछे थे on the symptom. Now in this NORCET exam उन्होंने पूछे questions on the treatment. So which therapeutic approach is considered first line treatment for OCD, often involving gradual exposure to the feared stimuli? Psychoanalysis, exposure and response prevention therapy, aversion therapy, supportive psychotherapy. So again, I'm sure we can now answer this. It is ERP therapy. Now aversion therapy क्या होता है? Aversion therapy means यहाँ पे हम noxious stimulus देते हैं. For example, mild electric shock दिया. Not commonly used, but sometimes again can be used in condition like paraphilias, even for substance use disorder. And supportive psychotherapy, when we are not able to use more detailed therapy, in that scenario we can sometimes use supportive psychotherapy. So remember यहाँ पे answer है ERP. Question. Next question is how BDD, body dysmorphic disorder, differ from other disorders. Now sometimes they'll ask question from these topics as well. So we have talked about all these important topics, be it our main classes, be it the fast track classes. So try to know these important disorders. So what is body dysmorphic disorder? So body dysmorphic disorder, we know, comes now under the newer classification DSM-5 also and ICD-11. They place it under obsessive compulsive and related disorder. तो इस कैटेगरी में एक डिसऑर्डर तो एज द नेम सजेस्ट OCD है. सेकेंड इज बॉडी डिस्मॉर्फिक डिसऑर्डर. एज द नेम सजेस्ट बॉडी डिस मीन्स एबनॉर्मल, मॉर्फिक मीन्स मॉर्फोलॉजी. सो पेशेंट को रेपिटेटिव थॉट्स हैं या प्री ऑक्यूपेशंस हैं दैट देयर इज सम डिफेक्ट इन माय फिजिकल अपीयरेंस. तो पेशेंट को बार बार ऐसे थॉट्स या प्री ऑक्यूपेशंस आ रहे हैं. फॉर एग्जांपल माय नोज इज लार्ज या माय नोज इज शॉर्ट, माय ईयर्स आर लार्ज, माय ईयर्स आर स्मॉल. सो पेशेंट को ऐसे बार बार रेपिटेटिव थॉट्स हैं. So this is body dysmorphic disorder. Again, in the management, cognitive behavior therapy can be used, and remember, even SSRIs have shown very good results in BDD. Some of the other disorders in this category, then there is hoarding disorder. Hoarding का मतलब क्या होता है? To keep on acquiring, चीजों को इकट्ठा करना है, not discarding them. So this is hoarding disorder. So patient may be accumulating books, magazines, old clothes, all those things patient may be hoarding. Then next is trichotillomania or hair pulling disorder. So patient को बार बार urges हो रही हैं to pull the hair, person starts pulling the hair. Most common area involved is scalp, although other parts of the body may also be involved. So most commonly you can remember it is scalp. It's a PYQ which has been asked. Excoriation या skin picking disorder. Person is now having urges to pick the skin and is now picking the skin, leading to skin lesions. इसमें most common area involved is the face. So remember the concept of BDD. Now let's come to this question. So it differs from other disorders. Option A, suicidal ideation due to BDD. Of course, it can occur in other condition also. Need of cosmetic surgery. Here there is no need, as actually there is no defect, but the person is, having this preoccupation of some imagined defect in my appearance. The person may compare with others, yes, but even in other conditions they may compare. Imagined defect in physical appearance, yes, that is the correct answer. So answer is option number D. Now let's come to the next question. A female reports of feeling like watching herself from outside her body, and this causes a lot of distress in her. What is the most likely condition in this scenario? Now let's see the option. Sometimes when you see such question, you may not be able to think of the answer right way, but let's see the option. When you see the option, you'll be able to answer the question. Dissociative amnesia. Now, is it dissociative amnesia? Now, in dissociative amnesia, we know it's a dissociative disorder. Dissociative disorder का मतलब क्या है? There is dissociation of one function of the mind from other functions like consciousness or memory or identity. One function is dissociated from other functions. Like in dissociative amnesia क्या होता है? That the person is having amnesia or does not remember certain events, usually of traumatic nature. So ये dissociative amnesia. For example, let us say a person was kidnapped for 2 days. 2 days के बाद पुलिस ने रेस्क्यू किया. पुलिस ने पूछा उन 2 दिनों में क्या हुआ? He does not remember anything. Person says मुझे उन 2 दिन से पहले का सब कुछ याद है, उसके बाद का सब कुछ याद है, बट वो सब्सिक्वेंटली वो जो 2 दिन है वो मुझे याद नहीं है. They were so traumatic कि माइंड ने क्या किया, वो स्ट्रेस कम करने के लिए the mind is using dissociation. So it does not remember memory of those 2 days. So ये dissociative amnesia. PTSD we know it is a trauma and stress related disorder. in the neurotic disorder वाले topic में भी discuss. So यहाँ पे क्या होगा, there will be some trauma. So there will be some major trauma they may give you, and then they'll give you symptoms of MAHI, which we have discussed with this mnemonic. So it is not PTSD. Of course, it is not schizophrenia. No symptoms of schizophrenia has been mentioned. Depersonalization, derealization disorder. This is again a disorder in the dissociative disorder category. Now let's see what is depersonalization, derealization disorder. Now, as the name suggests, depersonalization. So always try to remember things from the name. D का मतलब है feelings of detachment, personalization from self. So patient को ऐसा लगता है कि I feel detached from myself. Many a times patient uses this term as if. So person may say, as if I am watching myself from outside, like in a movie. So when we are watching a movie, the movie is separate, we are separate. So patient को लगता है as if I am watching myself, from outside, like in a movie. So this is depersonalization. Then what is derealization? Derealization, again see the name. यहाँ D का मतलब detachment, realization from the real world, from the world. So patient may say as if the world is unreal. सब कुछ बाहर बहुत unreal सा लगता है. So this is depersonalization, derealization disorder. Now please remember, if I ask you here, the reality testing is intact or impaired? Now you'll say, sir, we have discussed in that classification of neurosis and psychosis कि ये neurotic disorder है. In neurotic disorder, usually the reality testing is intact. So person may say, no, I know it is not true, but I am having this constant or regular feeling of detachment from self or from the world. So the right answer here is, as you can see, the person is having this feeling like watching herself from outside her body, and this causes distress. So this is derealization, depersonalization, derealization disorder. Next question. What category does a score of 20 on MMSE indicate? Again, many questions you will see have been asked from this topic of MMSE. Now, what is MMSE? It is mini mental state examination. Very important topic. Let's discuss what is MMSE, that is mini mental state examination. Don't confuse this from MSC. What is MSC? MSC is mental status examination. Now when we are examining a patient with psychiatric problems, that examination को हम बोलते हैं MSC. But remember, what is MMSE? नाम बड़ा similar, but they're totally different. So MSE is when we are assessing or examining a patient with psychiatric symptoms. Then MMSE is basically, it's a screening tool. So remember, MMSE is a screening tool which is used to assess cognitive functions. So MMSE में हम cognitive functions को assess करते हैं. Again, it's a less time is consumed here. 10 to 15 minutes में we can do this MMSE. इसमें हमारे पास total score आता है 30 और हम कहते हैं अगर score is less than 24, then it is suggestive of dementia कि patient में कुछ cognitive impairments हैं. So it is suggestive. Again, it is not a definitive test. So we have to further assess. It was given by Falstein et al. And sometimes known as Falstein test. So ये है MMSE. Now MMSE में again different guidelines have different scores of gradings. Let's discuss some of the what are the common grading score. So if it is less than 24, तो अगर score है 18 से 23 के बीच में, we call it as mild dementia. Then moderate में we say 10 to 17 is moderate, and severe we say if it is less than 10. So the question is, what category does a score of 20 on MMSE indicate? Is it suggesting of normal cognitive functions? No. Severe to moderate cognitive impairment, moderate cognitive impairment? No, it is mild cognitive impairment. So remember, the answer is mild cognitive impairment as per this grading. Let's discuss one more question. So another question was asked. A person is unable to recall 3 things within 5 minutes. The nurse in trying to assess, again, when we are doing MMSE also, we use this. So in MMSE also, there is one of the component that is recall. So we ask the person, we give 3 objects, which we have given previously, and then we ask the patient to again, after some time, to tell them. And if he is able to tell each of these 3 objects, we give 1 point. So maximum of 3 points on MMSE. So again, you can remember when we are talking about, assessment of cognitive functions. So what are we assessing here? We are assessing recall. So attention में usually we discuss tests like the digit span test, जिसमें digit forward test आता है and digit backward test. So we have in the digit span या digit repetition test में digit forward test and digit backward test. यहाँ पे हम patient को कुछ numbers देखते हैं and we ask the patient to repeat in forward or backward direction. ये test for attention. Concentration में we use tests such as 100 minus 7 test. So when we talk about memory को हम divide करते हैं into immediate memory, into recent and remote. Now immediate memory we say is memory of past few seconds, and immediate memory के लिए we don't use any specific test of attention and concentration usually in a way also tell us the immediate memory. Recent memory is memory of the past few minutes, hours or days. Sometimes we use tests like 24-hour recall method. Again, can you appreciate here we are asking something, again after 5 minutes, so we are trying to assess the memory. Remote memory हम assess करते हैं by asking personal information. So the answer here is, it is the memory which is being tested. Okay, so the answer here is option A. Let's see another question. So again, questions on organic mental disorder. So again, remember a small topic, organic mental disorder, now known as neurocognitive disorder. So you'll see some questions being asked from this topic. Again, MMSE is a very important topic nowadays. The questions are asked. Let's see this question. Which of the following statements accurately distinguishes vascular dementia from Alzheimer's disease? Now, again, we know that Alzheimer's disease is the most common cause of dementia, and usually it is the cortical dementia. While vascular dementia, we say it's a mixed, as we know, cortex or subcortex, both can be involved, in the beginning. So let's see the options. Vascular dementia has an abrupt onset related to a cerebrovascular event. Yes, that is a correct statement. So vascular dementia में, there is a vascular event which has occurred, a stroke or ischemia has occurred. So there is usually abrupt onset of symptoms, and usually it is related with the cerebrovascular event. Duration of vascular dementia usually brief. No, sometimes there may also be stepwise deterioration. So it is not totally correct. Personality changes are common in vascular dementia. In fact, when we talk about vascular dementia, usually more of complex attention impairment या फिर frontal की executive functioning impairment, that may be commonly seen. Personality change can occur, but it is again not a factor which will distinguish between vascular and Alzheimer's. Inability to perform motor activities occur in vascular. Yes, it can occur, especially if motor cortex or in the subcortical area, those areas related with motor functions are involved. But again, it is not always helping in the distinguishing. So the right answer here is option number A. So always try to see the options. Sometimes when you're ruling out the other option, you'll come to the right answer. So let's briefly discuss about vascular dementia, जिसे हम multi-infarct dementia भी कहते हैं, usually more common in males than females. You may see यहाँ पे vascular risk factors might be mentioned in the question, like patient को hypertension है, diabetes है, he is smoking, there is dyslipidemia या cardiovascular disease has been mentioned. So again, these risk factors can be present. Usually we know that there is acute onset of symptoms. So suddenly the symptom would begin. So along with cognitive symptoms, there may also be focal neurological signs. So depending on कौन सा area involved है, that corresponding area के जो effects होंगे that may also be seen. So focal neurological signs may also occur. तो आपको you'll be able to identify which area may be involved. And sometime we'll do an imaging, you'll also see certain changes in the imaging. So again, that is telling you that there is a cerebrovascular event. Now also remember, sometimes we see this step ladder pattern in the patient. So stepwise deterioration of symptoms sometimes you may see because of acute exacerbation corresponding to new areas of stroke. For example, एक patient को stroke आया at this point, so symptoms increased, एकदम से there is onset of symptom and symptom may come to a plateau. Let us say after some time there was another event, एक और event of stroke हुआ, so again symptoms may start and they may come to a plateau. There is another stroke, so again symptoms may occur like this. So this is step ladder pattern of deterioration which can occur in vascular dementia. So the right answer here is option A. Let's see the next question. So again, lithium is one important topic. So please revise lithium. Many times you'll see questions being asked from lithium. So before initiating lithium therapy, assessment of which of the organ function is not critical. Now options are liver function, B renal function, CBC thyroid function test. So what is the right answer? Now we know lithium, when we, remember lithium we discussed even in our school days, we would talk about lithium in the periodic table. So lithium, we know it's an element. So we cannot further metabolize an element. So it is excreted unmetabolized from the body. So it is not metabolized in the body and it is excreted through the kidneys, through the renal route. So please remember, so we need to check the renal function test. Agar renal function tests are impaired, we may have to decrease the dose because toxicity can occur. We know lithium can also increase these counts. So yes, CBC, and it can also interfere with thyroid function. It can cause hypothyroidism, even hyperthyroidism. So TFT function test is also required. So liver function not mandatory when we are starting lithium therapy. So let's talk about some of the initial medical workup when we are starting lithium. So KFT, that is the kidney function test, thyroid function test, electrolytes, CBC, ECG again is taken. And if a lady in childbearing age group we are starting, then pregnancy test, because we know that lithium can cause teratogenic effect. What is the name of the teratogenic effect? Epstein anomaly. Epstein anomaly, it's a cardiovascular defect which can occur in the baby if the mother is taking lithium in pregnancy. So these are some important initial medical workup which is to be done when you're starting a patient on lithium. See, one more question on lithium was asked. A patient on lithium therapy develops ataxia nystagmus. Which of the following is done? So patient is on lithium and develops some of these sign symptoms. So what are you suspecting? So options are liver function, renal functions, serum lithium levels, serum electrolytes. So clinically you may like to do many of these, but if you're asked one, so you're suspecting it is indicating lithium toxicity. So yes, here you will check the serum lithium levels. Now please remember one important concept about the lithium toxicity. Our body treats lithium like sodium. So our body is treating lithium जैसे कि सोडियम को ट्रीट करता है. सपोज किसी को डिहाइड्रेशन हुआ तो बॉडी क्या कर रही है? रीअब्जॉर्ब कर रही है सोडियम. बॉडी विल आल्सो रीअब्जॉर्ब लिथियम. टॉक्सिसिटी कैन अकर. किसी को डायरिया वॉमिटिंग हुआ, बॉडी इज रीअब्जॉर्बिंग सोडियम, बॉडी में आल्सो रीअब्जॉर्ब लिथियम, टॉक्सिसिटी कैन अकर. सो पर्सन इज डिहाइड्रेटेड, देयर इज वॉमिटिंग, डायरिया एंड पेशेंट इज ऑन लिथियम. अगेन try to see कि there are no signs or symptoms of lithium toxicity. So let's discuss some of these signs and symptoms of lithium toxicity. Lithium toxicity, we say it occurs when it is more than 1.5 milliequivalent per liter. So mild is 1.5 to 2 milliequivalent per liter. So you'll see a lot of GI symptom like vomiting, abdominal pain, and a lot of CNS signs and symptoms. Ataxia, nystagmus, muscle weakness can be seen. Moderate is when it is 2 to 2.5 milliequivalent per liter. यहाँ पे again anorexia is there, more nausea, vomiting, hyperactive deep tendon reflexes can be seen, convulsions, stupor, and even coma can occur. Or severe में when it is more than 2.5, generalized convulsions, oliguria, renal failure, even death can occur. And sometimes in severe cases, hemodialysis may also be required. So these are some points about lithium toxicity. See this. यहाँ पे पेशेंट लिथियम ले रहा है एंड पेशेंट कम्स विद ataxia nystagmus. So we are suspecting कि lithium toxicity could be there. So we'll check the serum lithium levels. Let's see the next question. So again, a very important topic of alcohol. In the substance, you'll see many times questions are being asked from alcohol. Question is, Cage questionnaire is used to assess the misuse of which of the following substance? So I'm sure you can answer this question. Options are alcohol, cannabis, cocaine, opioids. The right answer is option number A, that is alcohol. So let's talk about some screening test for alcohol, and one important test is Cage questionnaire. So एक acronym है Cage. सो व्हाट इज सी? सी का मतलब है हम पेशेंट से पूछते हैं डू यू फील द नीड टू कट डाउन ऑन योर ड्रिंकिंग। ए से है डू यू फील अनॉयड, देयर इज अनॉयंस जब आपसे आपकी ड्रिंकिंग के बारे में कोई पूछता है। जी से डू यू फील गिल्टी अबाउट योर ड्रिंकिंग। ई से डू यू नीड अल्कोहल एज आई ओपनर, मॉर्निंग में अल्कोहल लेने के बाद ही आईज ओपन होती हैं। सो इनमें से चार में से अगर एनी ऑफ दीज टू और मोर द पेशेंट सेज yes, then it is suggesting it's a screening test that patient may be having some alcohol related problem. We may have to further assess. Some other screening test you can also remember other than case there is audit. Audit क्या है? Alcohol use disorder identification test. One more you can remember is MAS, that is Michigan alcoholism screening test. You know, there are some tests for severity. One important test you can remember, SADQ. SADQ is severity of alcohol dependence question. So these are some important tests which you can remember. Let's discuss another question. Again, a question on alcohol. A known alcoholic patient presents with tremors and dysphoresis after 24 hours of not drinking alcohol. So he stopped drinking alcohol and now next 24 hours mein he is reporting of tremors and dysphoresis. Which of the following is most suggestive? Alcohol intoxication. Again, intoxication is not the scenario here. 24 hours have passed by. We're thinking of withdrawal, isn't it? It is not Wernicke's encephalopathy, which is a alcohol-induced neurocognitive disorder. ये होता है because of thiamine deficiency. So here, patient who is taking alcohol for a long time may develop this Wernicke's encephalopathy, and we remember the symptoms of Wernicke's encephalopathy with the mnemonic GO. So global confusion है, ophthalmoplegia है, ataxia है, then you're thinking of Wernicke's. ये होता है actually because of thiamine deficiency. Now we have two options. One is alcohol withdrawal, and delirium tremens is also seen in alcohol withdrawal. Now what is the right answer? So let's come to this table. Let's discuss important alcohol withdrawal symptoms. So suppose a person is taking alcohol and suddenly उसने stop कर दिया या suddenly amount को decrease कर दिया. So time after reducing or stopping alcohol, in the next 6 to 8 hours, patient may come with the most common withdrawal symptom is tremors. So patient may have tremulousness. Other symptoms like diaphoresis, increase in the blood pressure, anxiety, those may occur. But remember, most commonly earliest withdrawal symptom is tremors. Now suppose now 8 to 12 hours have passed by, withdrawal state continues. Now the patient may come with alcoholic hallucinosis. Patient may have hallucinations. Auditory hallucination may be seen, but other hallucination like visual, even tactile hallucinations can also occur. Agar withdrawal state may continue, some patients now in 12 to 24 hours may also develop seizures. Seizures may also occur. These are generalized tonic-clonic seizures, also known as rump fits. ये cluster seizures होते हैं, मतलब within a small span, a person may have multiple seizures in clusters. And if this withdrawal state may continue, some patients may eventually develop, up to 72 hours. Peak we say in 48 to 72 hours may develop delirium tremens. So very important. See, what is delirium? Whenever we say delirium, delirium का मतलब क्या होता है? Impairment of consciousness. So please remember, delirium का मतलब है impairment of consciousness. And we have always discussed, when you will see कि patient में they have mentioned in the question कि impairment of consciousness हो गया. So they may use some of these terms. So you can remember it with the mnemonic ACDC. What is A? Altered sensorium. So somewhere in the question they may tell you कि sensorium altered है. और C से they may tell you there is clouding of consciousness. और D से they may tell you कि patient is disoriented. So there is disorientation to time, place, person. So patient time को लेके, place को लेके, person को लेके disoriented है. और somewhere in the question they may just use this term confusion. So again, this term confusion is telling you that there is impairment of consciousness. Even in delirium tremens also there may be hallucination. Again, visual hallucination may be more than other hallucination like auditory. So this is delirium tremens. It is again a severe form of alcohol withdrawal, and again it's a medical emergency. Patient sometimes can die if it is not treated. So these are some important alcohol withdrawal symptoms. Every patient who is in alcohol withdrawal may not develop all these symptoms. So in more severe withdrawal symptom you will see seizures or delirium tremens. Now let's come back to this case. यहाँ पे पेशेंट को हो रहा है ट्रेमर्स, डायफोरेसिस. सो नोवेयर इन द क्वेश्चन दे हैव मेंशन्ड कि यहाँ पे कहीं इंपेयरमेंट ऑफ कॉन्शियसनेस है. तो यहाँ पे अगेन आई रूल आउट ऑप्शन डी. द राइट आंसर इज दैट इज अल्कोहल विथड्रॉल. लेट्स सी अनदर क्वेश्चन. An alcoholic patient presents to the emergency department with confusion, tremors, agitation, hallucination. Which condition now you are suspecting? So again, they are giving you a scenario that the patient is an alcoholic patient has come in the emergency. Now, is it Wernicke's encephalopathy? See, Wernicke's encephalopathy में भी confusion होता है, but there along with confusion you will see other symptoms like there is ophthalmoplegia, ataxia, right? Korsakoff psychosis or Korsakoff syndrome again is an alcohol-induced neurocognitive disorder. जिसमें you will see, amnesia is there, confabulation is there. Now, it is alcohol withdrawal, yes, but better answer here will be delirium tremens, because now they mentioned patient has developed confusion. So now patient has developed delirium tremens. That is the right answer. Let's see the next question. Which of the following is the first step in the management of delirium tremens? So again, they have asked so many questions on alcohol. Now, what is the first step in the management? Would you restrain the patient? Patient is very agitated sometimes. Lorazepam, haloperidol. So lorazepam, we know it's a benzodiazepine. Haloperidol, it's a first generation antipsychotic. And thiamine, it is vitamin B1. So what is the right answer here? Now we know that the drug of choice for alcohol withdrawal is benzodiazepine. So let's talk about the management. So when we are managing the patient, so here we are managing first is the detoxification phase, or we are managing the withdrawal symptoms. So always remember कि alcohol withdrawal. See, alcohol क्या है? It's a CNS depressant. Patient एक CNS depression था, रोज ले रहा है, suddenly उसने alcohol लेना बंद किया. So can I say brain will go in a hyperexcited state? तो जो alcohol withdrawal के symptoms हैं, like tremors is there, seizure is there. So this is telling me that now brain is in a hyperexcited state. इसको ट्रीट करने के लिए हमें क्या देना पड़ेगा? विल गिव अनदर CNS depressant. So drug of choice of alcohol withdrawal is benzodiazepine. So we can use benzodiazepines like lorazepam, diazepam, oxazepam, clodiazepoxide. Now suppose they tell you in the question कि patient के जो LFTs हैं, they are deranged. So liver is compromised. It is possible. Sometimes patient who is taking alcohol, the liver may be compromised. So in that scenario, remember liver okay benzodiazepine. मतलब कौन से benzodiazepine you can give even if there is a liver damage or liver is compromised. So L से remember lorazepam, O से remember oxazepam. Now also remember, अगर आपसे पूछते हैं management of alcohol withdrawal along with benzodiazepine, would you like to do something else also? Yes, you can also add thiamine. So thiamine may also be added. तो अगर आपसे पूछे अल्कोहल विड्रॉल की ट्रीटमेंट, ड्रग ऑफ चॉइस इज बेंजोडाइजेपिन, बट अगर एक ऑप्शन है बेंजोडाइजेपिन प्लस थाइमिन, दैट मे बी अ बेटर आंसर. सो लेट्स कम बैक टू दिस सिनेरियो. सो अगेन हैलोपेरिडोल, अगेन नॉट नेसेसरी, मे बी इन मोर सिवियर केसेस एजिटेशन बहुत ज्यादा है, देन वी मे थिंक, बट अगेन हियर इट इज नॉट द फर्स्ट स्टेप. विल नॉट रिस्ट्रेन द पेशेंट एज द फर्स्ट स्टेप, इजंट इट? अगेन थाइमिन इज नॉट द ड्रग ऑफ चॉइस. हाँ, ऑप्शन में अगर लोराजेपैम प्लस थाइमिन हो तो दैट वुड हैव बीन अ बेटर आंसर. तो यहाँ पे द आंसर इज इट इज लोराजेपैम. Let's see the next question. So again, there have been questions on child psychiatry as well. The IQ range of 50 to 69 falls under which of the type of mental retardation as per DSM-5 classification? Mild, moderate, severe, profound. So let's talk about mental retardation. Please remember in DSM-5, now the term used for mental retardation is intellectual disability. Which is the most common genetic cause of mental retardation? Remember, Down syndrome. Now what is Down syndrome? Down syndrome is trisomy 21. Second most common genetic cause for mental retardation, remember, it is Fragile X syndrome. Now suppose if I ask you the most common single gene cause of mental retardation, but please try to read the question carefully, because sometimes you're thinking of genetics, you may just mark this as Down syndrome. देखो, Down syndrome is a chromosomal abnormality. If they ask you most common single gene cause or most common inherited cause, then you will choose again Fragile X syndrome. So again, we can divide into the severity: mild, moderate, severe, profound. So mental retardation, we say when the IQ is what? Intelligence quotient is less than 70. So mild may we say the IQ is 50 to 69. Moderate may we say it is 35 to 49. Severe may, remember, we say it is 20 to 34, and profound may we say it is less than 20. So what is the right answer here? 50 to 69. It falls under the category of mild mental retardation. Let's come to the next question. So again, another question from child psychiatry. A 4-year-old boy does not speak or play with others and becomes, so can you appreciate that there is deficit in social communication, and becomes panicked when surrounded by people. He prefers a fixed routine and shows distress when it is changed. So there is a repetitive pattern of behavior also. Which of the following would be the most appropriate intervention for this child? Now whenever such question comes, always try to first identify that what is the diagnosis or what symptoms are present. So can I say there is decrease in the social communication? So the social communication is decreased, and also there is a repetitive pattern of behavior in the child. So what is the diagnosis? So the diagnosis is ASD, that is autism spectrum disorder. Options हैं CBT, ABA, that is applied behavior analysis, exposure therapy, or psychoanalysis. Now, we know in autism spectrum disorder, these are the two core features: deficit in social communication and repetitive restricted patterns of behavior. Some of the disorders under this category include autism, Rett syndrome, Heller syndrome, Asperger syndrome. Please remember, Rett syndrome is one important disorder which is more common in females than males. Now, in the intervention, usually we use psychosocial interventions. In that, we use behavioral interventions. We try to modify the behavior. So we use applied behavior analysis, that is ABA, to increase certain behaviors. So certain behaviors which we want the child to do, and we want to decrease certain behaviors. So we use the principle of applied behavioral analysis, and we target social communication and usual some of the behavioral skills. Then also parent training, social skills training, behavior therapy, CBT, these can also be used. For example, child is having anxiety and other symptoms, these also can be used. Educational interventions are also used. So remember, in this, the answer will be applied behavior analysis. Drugs again can be used, if there are certain symptoms for certain targeted symptom, we can also use drugs. But remember, psychosocial intervention usually play an important role in the management. Which of the following therapy is most commonly used for borderline personality disorder? Again, when we talk about personality disorders, we've divided them into cluster A, B, and C. Cluster A personality disorders may we know is paranoid, schizoid, schizotypal personality disorder. Cluster B में antisocial, then borderline, histrionic and narcissistic personality disorder. Cluster C में there is anxious avoidant, dependent and obsessive compulsive personality disorder. So borderline personality disorder is a cluster B personality disorder. Usually in the management of these personality disorders, we use therapy. For borderline personality disorder, options में CBT है, psychoanalysis है, play therapy और DBT. Yes, the answer here is dialectical behavior therapy. Now, what is borderline personality disorder? Let's discuss some important points. It is more common in females than males. Here, the person has unstable interpersonal relationship. So, person may say, one day the person may say, you're the best person I know. You are like an angel. But then the person may say, you're the worst person I know on another occasion, get out from here. So the relationships are unstable. The person may be very impulsive. There may be recurrent suicidal behavior, gestures, or threats be, you can see. Mood may be very unstable, without any reason, anger outburst हो सकते हैं. Person may report of chronic feeling of emptiness. So person may report that, sir, ऐसा लगता है that nobody is there for me. Now, in the management, in the psychotherapy, remember it is the dialectical behavior therapy, that is DBT, which is used. So it was developed by Marshall Lenihan. Initially, it was developed for chronically injurious and parasuicidal behavior, but now it is also one of the therapies used for borderline personality disorder. यहाँ पे हम क्या करते हैं, जो problematic behavior है उसको decrease करते हैं, जो emotional pain the person is experiencing, we try to decrease that emotional pain by acceptance, by accepting that emotional pain. And various other strategies are used. So remember, dialectical behavior therapy is the important therapy for borderline personality disorder. Now see this next question. Which of the following is done in nursing intervention in patient with bulimia nervosa? Now you'll see sometimes question being asked from these topics as well, like eating disorder. Past may they've asked question on anorexia nervosa also. Option is observe patient for 2 hours after each meal. Nasogastric feeding, allow the patient to eat any amount of food, give punishment on binge eating, purging behavior. Let's see what is bulimia nervosa. Now, bulimia nervosa is a eating disorder. We know more common in females than males. यहाँ पे एपिसोड्स हो रहे हैं बिंज ईटिंग के. बिंज ईटिंग का मतलब क्या है? पेशेंट लेस अमाउंट ऑफ टाइम में इज ईटिंग अ लॉट एंड देन द पर्सन यूज इनअप्रोप्रिएट वेज टू कंपनसेट और प्रिवेंट वेट गेन. तो कंपनसेटरी बिहेवियर कैन बी पर्जिंग बिहेवियर, जैसे कि सेल्फ इंड्यूस्ड वॉमिटिंग है. Sometimes patient may use laxatives, diuretics या emetics. Please remember, sometimes non-purging behaviors can also be done. कि patient ने binge eating किया, उसके बाद excessive exercise किया, या कुछ दिनों के लिए dieting या fasting किया. So that also may be diagnosed as bulimia nervosa. So please remember, it is not always कि सिर्फ self-induced vomiting मिलेगा. Some other compensatory behavior may be present. तो bulimia nervosa, please remember, यहाँ पे जो weight या BMI है या तो normal होगा या maybe the higher side. Because anorexia nervosa may be there is one binge eating purging subtype. Differentiate कैसे करेंगे? Anorexia nervosa में weight या BMI is low. यहाँ पे it may be normal or maybe at the higher side. Now in the management, please remember again, it is the psychosocial intervention which is preferred. So we'll psychoeducate the patient, focus on the normal eating patterns. CBT is the preferred treatment modality for the management. यहाँ पे CBT में अगेन कॉग्निटिव टेक्निक्स या बिहेवियर टेक्निक्स हम यूज करेंगे, हम इंटरप्ट करेंगे सेल्फ मेंटेनिंग बिहेवियर साइकिल ऑफ बिंज ईटिंग पर्जिंग, ऑल्सो विल ऑल्टर पेशेंट के डिसफंक्शनल बिलीफ हैं फूड को लेके, अपने वेट को लेके, बॉडी इमेज को लेके, इन टोटल अपनी सेल्फ कॉन्सेप्ट को लेके भी देयर में भी सम डिसफंक्शनल बिलीफ, तो हम उनको भी ऑल्टर करेंगे. सो हम कॉग्निटिव टेक्निक्स एंड वी यूज बिहेवियरल टेक्निक्स. रिमेंबर ड्रग्स कैन ऑल्सो बी यूज सच एज SSRI, बट अगर प्रेफर ट्रीटमेंट पूछते हैं दैट इज CBT. नाउ लेट्स कम बैक टू दिस क्वेश्चन. Will you observe the patient for 2 hours after each meal? Yes. What if the patient is doing self-induced vomiting, or patient is using some of those compensatory behavior? Because nasogastric feeding is not usually required because patient is eating. In anorexia nervosa, sometimes when the patient is not eating, then you may use. Would you allow the patient to eat any amount of food? No. That again is not advisable, isn't it? Give punishment, again will not use techniques like punishment, but we'll try to use some of the other techniques. So the answer here is option A. Let's see another question. So again and again they are asking questions on ECT, again a very important topic. Sometimes they'll ask questions on procedure, what are the things you will do before or during or post ECT care, what things you will do, what are the drugs which are used. So all those things you should know. Many times they are asking questions. Which of the following is the highest priority nursing action before administering electroconvulsive therapy and ECT? Remove all the jewelry from the patient. You will do this, but let's see all the options. Ensure the patient is NPO for at least 6 hours. Yes, NPO, remaining NPO is very important. Administer prescribed pre-medication, that also is to be done. And remove nail polish, not be that mandatory. So see, out of these options, what is the best answer? Yes, it will be that you will ensure the patient is NPO, because if that is not there, risk of aspiration can occur. We cannot give ECT. So let's talk about some important points, when we are giving ECT. So preparing the patient, first and foremost, very important is informed consent. That is very important. Before, without informed consent, we will not be able to do ECT. So that is very important. NPO for at least 6 hours before treatment, yes, to prevent the risk of aspiration. Empty the bowel and bladder just before ECT, yes, we'll instruct the patient will be wearing loose clothes. Remove any ornaments or any articles are there, any prosthesis like glasses or hearing aid, those should be removed. Hair should be dry, yes, again if there is any problem in conduction of electricity, so we'll try to remove. So hair should be dry. Before the procedure, check the patient's mouth for any denture, any foreign object, again that can cause complication. Establishing IV line, that is important. Bite block we insert in the mouth just before giving ECT, again to prevent injury to the teeth, to the tongue. So these are some important points. Again, also remember informed consent, monitoring the vitals, that also becomes very important. So in the question, out of these, you can see the better answer would be you'll ensure that the patient is NPO for at least 6 hours. So these were some important questions which has been asked, and we try to discuss these questions so that you get an idea कि किस तरह के questions आ रहे हैं, and what are some of the important topics. So again, in these coming days, one message I always say, don't think too much about that exam day. Take one day at a time so that you are able to focus on that one entire day. आप अपना best दे पाओ उस दिन. So just focus on that entire day, and even in that day, focus on that one particular session of that day. So take things step by step, and you'll see that you'll be able to handle the anxiety. And as I always say, keep a smile. Exams sometimes can be a stressful situation. So keep a smile. Study, but have a smile so that you're not taking anxiety too much, and keep moving forward. Take one day at a time, and everything will be fine. So with this, we'll conclude this session, and all the best to all of you for the prelims and the mains exam. Thank you. May God bless you.